Wonderful. This is a great group today. Thank you all for being here. Happy to start off with another integrated care roundtable for the month of November. We're going to talk about tobacco cessation today. This is a CE opportunity. So if you are seeking CE credit for today's event, be sure to be registered on mopaonline.org. If you haven't done that, you can still email Emily at support@mopaonline.org, and she'll follow up with you to make sure that you're registered. If you're signed in through Zoom without your full name, if you won't mind changing your name to your full name, that would help us expedite the CE process. Reminder that this is a discussion, not a seminar, so please jump in. This is very interactive. We want your input on each topic, and so anything you have to say, you're welcome to. You can also use the chat if you don't want to turn on your video and audio. And you can always just turn on audio if you also don't want to turn on your video. I know some people are eating while we're doing that, and that's perfectly fine. Also, just a last minute reminder that this is being recorded for future use of MOPA. The views and opinions expressed during this roundtable are our own and yours, and do not necessarily represent the views of any of the Missouri Psychological Association. So happy to start off today introducing the panelists. Robin, I'll start with you, and if you don't mind to tag somebody in after that.
Sounds good. Thanks, Chelsea. So hi, everyone. I'm Dr. Robin Lute. I'm a licensed clinical psychologist working in a federally qualified health center, CCBHO, if I got that one right, Compass Health. So I'm excited to be here with you today, and I'll popcorn over to my fellow Compass Health employee, Michaela.
Hey, everybody. I'm Michaela Muehlbach. I am a licensed psychologist, and my role at Compass is to oversee our outpatient and psychological services, which includes BHC and school-based services. I also was a BHC at one point, and integrated health is near and dear to my heart. So we are so happy that every month we get to hang out with y'all. And so I will pop it over to Miss Micah, who is our guest panelist today.
Hi, I'm Micah. I am a licensed clinical social worker. I work as a behavioral health consultant with a partnership through Burrell Behavioral Health and Cox Health Hospital. So Chelsea, do you want me to send it back to you, or is that enough with the introductions?
Sure, that'd be fine. I'm Chelsea Gillum. I'm a licensed clinical psychologist. I am the system director of integrated care at Burrell Behavioral Health. So I help manage all of our clinics that have embedded providers. Also was previously a BHC, like Michaela said, and so it is also near and dear to my heart. I would say that I'm really glad that we're having this discussion today. I think it's a much needed one. We probably should have this discussion more often. I was just reading some statistics the other day, and it said 4 in 9 tobacco users who recently saw a health professional in the last year didn't get advice about reducing tobacco use. I hate the word advice, but they didn't get any support. And I think there's a lot of reasons for that, but it really speaks to the fact that it's important that we are in these spaces, because tobacco use is the leading cause of preventable death in the United States still. And this is something, although it's on a decline, we have to be addressing this in all the spaces that we're in. I want to start off just talking about some of the reasons for tobacco usage. I think that's a good place to start. And I also wanted to just pose that to the individuals that are here listening today to see if we're going to increase some participation. So we're going to start off with that. And what are your thoughts on what are the reasons for tobacco usage? So I'm thinking
I'll throw a couple in,
Sure.
if that's all right. Certainly this is non-comprehensive, but a couple of things that come to mind. I'm almost coming from a little bit of a prevention lens, would be sort of glamorization of smoking in movies or advertisements, as well as good old-fashioned peer pressure and wanting to fit in.
I'll jump on that as well. So, one of the things I've seen as points of root causation would be familial. growing up in the environment, the social, psychosocial properties as well. You have individuals that, you know, the in groups that you're part of, if they're doing it, you want to do it as well. Another part of that is a big social aspect. Now we see that, you know, individuals that are out with, you know, in a party scene or something of that nature, somebody that might not naturally, you know, pick up the habit or go that route, will due to out of access or due to proximity. And unfortunately, we do know that due to the addictive, you know, characteristics of this, it doesn't really matter the baseline. But one of the things I have noted is that typically in these states of usage is almost always secondary. There's always another underlying reason that was the precipitous moment that brought this to fruition.
Throwing out there, I'm absolutely agree with what's been said, and thinking too about the kind of psychological correlates that go along with smoking. And so certain kind of already existing co-occurring disorders that increase the likelihood of this behavior being prevalent. So for example, we have a strong body of research that supports that individuals with schizophrenia oftentimes smoke at a higher level, on a higher rate than others. And also when you think about a couple of months ago, we talked about eating behavior, and you know, using cigarettes and tobacco as an appetite suppressant and a weight management tool is often something that we see. And so sometimes these are kind of to both the points that have been made of thinking about not only our like culture, our societal kind of pressures, but also that kind of like biological space that we kind of have to fight against sometimes with regard to the urges that go along with those particular diagnoses.
Michaela, I would piggyback on that. Hi. That I am the director of our healthcare home at Compass Health, and so tobacco use among the general population sits at about 14% right now. In the Compass Health healthcare home, it's at 56%. So that just shows you the disparity between people who have, as Michaela was saying, those co-occurring disorders. So both an SMI and chronic health conditions, much, much higher rates of smoking. And they smoke differently than people who don't have SMI. They tend to smoke, if they're smoking cigarettes, they tend to smoke the cigarette down lower, lower. Oftentimes you see like burn marks on their fingers. They take longer drags, so they are getting more nicotine per cigarette than the general population as well. So just thought I'd throw that in there.
When your statistics were, I was thinking about that in my head as well. I think on average, there's about a 20% difference in the average population and an SMI population and their ability to quit. I think it's somewhere between 30% versus like 50%. It was spot on. That's interesting. You're absolutely seeing that in practice as well. You know, we're not just reading that, you're actively seeing that. One of the things I will add to this is, you know, we try to talk about diversity and special populations also in here. And what came to mind for me as we were talking about this is kind of some intersectionality with poverty as well. We know that low-income communities smoke at a much higher numbers than the rest of the country. And a lot of that disparity then is rooted in inequities. And so I don't want to fail to mention that. Those individuals usually have the least information about health hazards, fewer resources and social supports, often have less access to services to help them quit. And on top of that, the tobacco industry has a long history of actually targeting these individuals. Their advertising campaigns toward low-income neighborhoods and communities are staggering if you look at the numbers on that. There are significantly more tobacco retailers in low-income neighborhoods, and they have historically targeted women and low SES through distribution of discount coupons, point of sale discounts, direct mail coupons, development of brands that appeal to women. And so it's interesting because I often hear individuals make comments about individuals in poverty or smoking, right? Because sometimes this is generally thought to be an expensive hobby, a habit. It's not. Actually, we need to increase the cost of cigarettes. We would significantly reduce the amount of young individuals and individuals in the sect that are smoking. And so I just think about, as far as coping, this is a very cheap way in the scheme of things to cope compared to individuals that maybe have more options. You know, it's maybe not the most healthy thing, but neither is a 14-day ayahuasca yogi retreat. So my thoughts on that.
I also think, sorry, to that point, I was thinking there's actually been a lot of studies that show that depression and anxiety actually reduce when people stop smoking. But a lot of times, because of the receptors in the brain and how quickly tobacco and nicotine get to those receptors, it's actually the opposite, that a lot of times the depression and anxiety are increased from smoking. And so when we can help people find alternatives or kind of work to develop those healthier coping skills once they quit, there's a lot of research to show that depression and anxiety will actually significantly reduce. Whereas before they're smoking and they're thinking, oh, I'm doing this to help with my anxiety and depression, it actually does the opposite of that.
I often, at least in the short term, Micah, think about that relief from anxiety and depression as actually getting oneself out of withdrawal, right? So that tension building cycle where the blood, the blood level of nicotine is decreasing and people are saying, I feel stressed out, I need a cigarette. When you break it down from a physiological perspective, it's actually, I'm going to feel better because I'm not going to be in withdrawal. And I do want to hop back to something that Chelsea said a moment ago about targeted ads and kind of policies related to advertisements and billboards in low-income neighborhoods. That often happens more significantly, more densely, promoted in racial and ethnic hotspots areas. And the comment about it being costly, Newport cigarettes, and this is just one that comes to mind, actually decrease the cost of cigarettes in high population African American neighborhoods, which it almost would feel like the opposite, but they are willing to kind of take that initial dip in revenue to hook somebody and to keep them coming back for more. And so there's additional studies and evidence that show that neighborhoods that are primarily white have a certain number of advertising per mile, let's say, and as those neighborhoods become increasingly diverse, tobacco companies will put more effort and more money into specifically advertising to certain populations, making, really targeting how the advertisement looks to hit specific populations. And that, I won't hop into this just yet, but that really emphasizes what we do with policies and what sort of ethical responsibilities do we have from a public health perspective in terms of increasing costs of cigarettes and regulating how much marketing can be done in a specific area and to specific populations.
Individuals really struggle with quitting. This is actually very difficult to treat as well, and as we know, which I could go back to saying that's probably the reason that we see a lot of individuals going into the healthcare system. They go in, they get asked the questions because most EHRs require that at this point, but they don't feel like they're getting any follow-up. I would say partly because the system's overwhelmed, right? Turning out people as fast as widgets in a widget factory in a medical system. It's a broken system. I think they're overwhelmed. I think they're also just not quite sure what to do. They don't have a lot of time. And usually what we do isn't working. So it's hard to feel like I need to keep doing this intervention and it's not working. I also think they probably are sending out information in the discharge packet and saying that is the counseling that's done and the patient's never seeing it. So I think there's a disconnect in the communication where the health system often thinks that they have done some counseling, whereas the individual feels like it hasn't been addressed whatsoever. But that brings me to smoking it's hard to quit, or tobacco use is hard to quit. Micah hit on this a little bit earlier, but I wanted to bring up, like, why is it in our perspective that quitting is difficult for these individuals?
Sorry, I lost a headpiece. Yeah, I can touch on that a little bit more. So the cool thing is our brain is really amazing, right? And I've had a patient very recently in the past 2 months tell me it was so much easier for me to quit meth when I was homeless than it is for me to quit smoking while I have a stable job and a stable home life. So I just thought that was really interesting. But what's happening in our brain is that because nicotine gets to our brain so quickly, it's firing off these receptors, and these receptors continue to grow and strengthen so that they're much larger than someone who doesn't or who hasn't ever smoked. And so these receptors have memories, right? So they're very easily triggered by cues, by things that the person has paired with smoking. So we think about smoking when you're driving, smoking while you're drinking out with friends, smoking while you're sitting outside. And so our brain is remembering these things. The nicotine is getting so quickly to the brain that it's really hard to quit, because what they're feeling, like Robin was saying, is that withdrawal. And so that withdrawal is really powerful and it's really difficult. And it takes a lot of time to calm those receptors back down to where they're not firing off as often as they are.
Absolutely. And kind of thinking about that paired association of the withdrawal, and we're pairing this with an anxiety decrease. I think too about like our environment. Smoking, before the legislation and the laws in Missouri changed and people weren't allowed to smoke inside anymore, I mean, it was such and is a social thing. And we talked in our kind of preparation discussion of this about how it's also paired with other behavior like drinking. And if they like methamphetamine use or any other stimulant use, that oftentimes individuals smoke, it's kind of like that non-goal directed behavior. I've got to do something with myself. And so this is something to do. And it's really kind of thinking about the treatment of smoking and cessation is so much of that I think requires, because it's such a multifaceted concept and such a multifaceted issue, I think that it's going to take a multifaceted approach. Yes, the discharge paperwork is great to have that information in there, but thinking even on the front end of provider education of smoking and what this looks like and how it presents and how we wrap our services around individuals while they're in healthcare, our healthcare systems. I think that's a huge piece of it too. And I think that has to, by necessity, be multimodal and take so many different parts and people probably to do it.
To hit on that, Michaela, I was thinking so often when we go in and integrate and embed a clinician in a health system, it's not just the physicians that the provider's working with, it's the entire system. And so when we think about broken systems, integration really requires you to not only just go in and provide integrated care, but also system integration. And sometimes that means we need to be informing the system that they need to do better, or these are the things that they could do differently, using that expertise wisely.
You know, something else too that comes up, I think, is excuse me. There's the lesser of two evils type of approach that I've heard come up a few times. Of all things, despite the fact we know the transitory effects of what nicotine can do to your system, everything that goes along with it, you know, in light of other addictive situations, though, usage can be seen as, again, the lesser of two evils, and sometimes it's propagated in such a way that even though it's not bad, it's not as bad as something else. So if we're going to focus on something, focus on the things that are more detrimental to one's livelihood, their next steps. So under those circumstances, what you have then is an opportunity where an individual may not necessarily think that it's bad enough to do something about. Psychologically speaking, they may think that, you know, it's bad, but it's not. No, it's not going to, you know, I dare say not kill me, but they can convince themselves. The brain is hyper powerful to convince themselves that even the most negative things are still relatively positive by comparison to something else. So if you have those type of situations happening, depending on how we go about treatment purposes and processes, that can actually have a detriment as well. If we're not taking the severity to the right degree and trying to find the best way to inform, as to, again, like what Michaela was talking about, trying to find a way to systematically get multimodal in the approach, because without there's all kinds of circumventing processes and paths that one can go down to relegate this down to not being necessarily something they need to do something about, but more like a societal push to do something about.
And along those lines, we have certainly seen, for the most part, rates of smoking and nicotine use actually decrease over the last several decades, at least in part to many policy measures. And so it just gets me thinking, one very simple thing that comes to mind, Justin, is you're saying, it doesn't necessarily appear that it's dangerous, even though we know it is, or, just from a pure policy perspective, it's legal. It's, as Chelsea said, it's relatively and I'm not suggesting we go out and say, please use illegal drugs instead of legal. I know that's a whole different concern, but there is a societal message on some level, if something's legal, that it's okay or that it's safe, even if we put that little warning box on there that nobody really reads. A lot of studies have shown that pure information, just telling people adverse risks, is not necessarily the driver of behavior change.
So it seems like a natural transition to talk about how we treat this. What does intervention look like, maybe at a patient level, maybe at a systems level? What are your thoughts on that?
I kept thinking about good old-fashioned motivational interviewing as people were talking. I did the Mayo Clinic training to be a tobacco treatment specialist. And one of my favorite questions that they kind of posed to people to ask was, what are your thoughts and feelings about quitting smoking? It's a really non-judgmental, non-shaming way to kind of bring that up. And then using those scaling tactics to elicit change, asking permission to share information on why that might not be true, that even though this is legal, why it might not actually be a great thing to engage in, or how we might at least be able to identify other healthy ways if they're interested in that. And then the other thing that I found to be really helpful with the patients I work with is planning for more of a step down process instead of a let's quit cold turkey, have fun, bye kind of process of how do we work together to make this to where it is a more attainable goal? How do we set this very large goal, quitting smoking, into something that feels more reasonable? And sometimes people stop there. I've had a lot of people where they said, you know what, I just want to get down to where I'm smoking a pack a day. And if I could smoke 5 a day, I'd feel much better about myself. And that's great. I don't usually, for that, I just say, wonderful, I love that goal. How can we make that possible? And then I really work with them on helping to plan what that step down is going to look like. The tobacco treatment program did say to set your quit date, if that's their ultimate goal, within 3 months of that. So that way it doesn't feel so far out. It's not something where it's this, 2-year goal we're working on, but it's within 3 months of what they say. And I have a lot of people who like that, and they kind of take that and play with it. Oh, I've got some time. Okay, good. This isn't all together all at the same time.
I think sometimes clients will want to choose quit dates that have another meaning in their life. It's my anniversary, it's my birthday. And there's actually some research around the idea that may not be a great idea. So if your anniversary is coming up and you become a non-smoker and then you get a divorce, that's going to be a trigger, just as an example. So trying to find a neutral but amenable date within those 3 months. That's just a small piece that comes to mind. I also wonder, Micah, maybe for you or maybe for someone else who's attending, we've mentioned multimodal, finding something that works for people, stepping down. What about the use of nicotine replacement and kind of taking a multi-pronged approach to kind of mitigating that severe withdrawal, so to speak.
Yeah, it's interesting because I know I work with a lot of physicians who will say that if you have a patient who's quitting, they would not recommend taking any other nicotine replacements during their quitting. But that's actually the opposite of what our training said. Was it's use those nicotine replacements, the patches, the chew, the lozenges to help with the urges. And then once that quit date has happened, they said within 6 months, we want to make sure that that person is getting off of those, that we're taking them off of those replacement products. I work with a lot of physicians and we like to use Chantix a lot, but sometimes that's not helpful. Wellbutrin is also another proven one to be very helpful. It can also be great if we're treating comorbid depression or anxiety, right? We're looking at the mental health aspect of that. So a lot of times I talk with patients on use those things. I will say with the lozenges and the gum, a lot of people just treat them like they're normal mints or normal gum, which is actually not going to be very helpful because it's going to cause some upset stomach, some different GI issues. And so I usually will print off kind of step by step how we use these things. And it's actually, you just stick it in the side of your mouth until it dissolves for the lozenges. For the gum, you chew it once or twice until it starts to get a tingly feeling, then you put it in the side of your mouth. So I always print these off. I don't assume that people know how to do this. And so when we talk about the importance of these are to help you to get through these cravings. This is kind of what we're using as a an all systems approach.
I love these thoughts, and it made me think too about like some of the reasons why people stop their quit plan. And a lot of people, by the nature of our human nature, is that we're pain averse. And so, like, we experience a lot of these things as emotionally, mentally, and even physically painful. And so that makes us want to go back to the thing that made us not feel that way. And so I think about like whenever you start an exercise regimen, you are so sore, and that's very painful. Nobody wants to feel that way. And so we're like sitting on the couch was actually fine. And so when I think about this, I think about an individualized approach. Like sometimes nicotine replacement is what a patient kind of needs to get them to that place. Sometimes having a Band-Aid pulled is what is needed. And sometimes like a more concerted stair-stepped approach is also what's needed. And so I think about that individualized approach, which makes me think about the places that individuals show up in different aspects. And so primary care is definitely a space that we focus a lot on smoking cessation. And even in the outpatient realm, so it's a little bit of a bias of mine with being kind of in the outpatient therapy space. That's where a majority of our patients are seen. We provide a ton of nicotine kind of education and screening. So most of the people, even if they end up in primary care, we're going to be screening them and seeing them in outpatient therapy. And so to that end, that may be the level that a person needs. But if it's not, then we can amp it up and have them go through really more focused tobacco cessation, even through our primary care space. And so I think that's just another layer to this of you take an individualized approach, you create the treatment plan that works best for them, and whatever environment that has to happen in is maybe what is needed.
I love that idea of personalizing the plan. Of course, we all want to aim for that as much as possible. And in most of our interventions is to really tailor to the client. It does, again, for me, bring up some of the racial and ethnic differences and even how people smoke. There are different patterns. We talked earlier about different diagnoses, individuals with different diagnoses who may smoke in different ways. African-American populations, for instance, are actually less likely to smoke and to be more intermittent smokers. They don't often have a first cigarette within 30 minutes of waking like many white populations do. Yet their quit ratio is not as effective as what happens for white populations who access treatment. So, again, a part of that may be that some, just as an example, if a person holds a non-smoking ban in their household, they're more likely to effectively quit. And so, oftentimes Caucasian or white populations will go with that or will implement that, whereas African-American populations don't at such a high rate. So there's really, that personalization can come in all kinds of ways. Latinas and Hispanic Americans are simply less likely to use nicotine replacement therapy, even if and when it's offered. It tends to be offered less to that population, but even when it is, it's something that they're less likely to utilize. So kind of keeping, just not just at the personal level, but what are the other contextual factors, racial factors, cultural factors that may help us to help clients be more successful, really targeting.
We are at the 34-minute mark, so I just want to take an opportunity and hold space for anybody who would like to say anything or ask a question at this point from the information that we've talked to up until now.
I just like to go back to some of the things that you said earlier about the larger forces, the tobacco industry. I went to Wake Forest University, and some mornings you could walk out the dorm and smell the tobacco. And one time I stayed at someone's home whose husband had died. He worked for Reynolds and he died of lung cancer, and they were well compensated. So it's just, when you talk about tobacco companies even targeting low income populations, that's at the mega level. I mean, and we as individuals probably don't have a lot that we can do to affect that, but I think it's important to be aware that is there. The other thing is that, as someone mentioned, how Missouri, you used to be able to smoke in stores. And I remembered that when I first moved here and somebody was smoking in a grocery store, and I hadn't experienced that before. And I suspect that as more workplaces have become non-smoking, that has probably helped. And I also wonder if that may have affected white populations more so than Black populations, because more white collar workers is being outdoors where smoking is not as much of an issue. So just that there are lots of factors. There are all kinds of smoking cessation techniques that have been around for decades. And so there are a lot of things that you can choose from to work with an individual to help them stop. But I hadn't given as much thought to the larger picture of companies actually targeting groups to sell their cigarettes and promote different kinds of smoking. And of course, vaping now has become an issue.
Nancy, I love those comments in terms of looking at the broader policies, and you are right on that. Studies do show that workplaces who put in full smoking bans, yay Compass, actually show decreases in the use of nicotine in their workers. There are several states, kind of more in the Pacific Northwest area, who have worked to increase the smoking age to 21 rather than 18, which has also shown reductions in smoking. So I know you said maybe there aren't things or delays in people starting smoking, for instance. So there may not be a lot we can do, but we can vote. We can, if there's a measure for increased tax on cigarettes, we can certainly vote for that. Some of us may get kind of, lit up, no pun intended, about this topic and maybe want to be more involved in policy. So I really appreciate that, because a lot of smoking has gone down quite a bit when we've implemented bans and sort of said you just can't do it here. It's natural means restriction, right?
And I do find for myself that whenever I interact with the healthcare system, I'm always asked about my smoking history. And I'm sure that if I had said yes at any point, they would have offered me some information. You know, fortunately, I grew up in a non-smoking household and never smoked. But again, it's those of us who are better off financially who are going to be getting regular health care. And it's the folks at the lower end of the spectrum who may have difficulty either affording it or getting access to it. And so they're not getting as much information about problems with smoking. And something that made a big impression on me some years ago, the Science Center had this exhibit of bodies. I don't know if anybody remembers that. And they were cut open and you could see how black the lungs were of people who had been smokers. You know, they're just very striking. I know that a negative approach to trying to scare people out of smoking may not be the best way to go, but there are certainly things that would give people pause if they could understand how smoking would affect them over time.
It reminds me that there's a handout that I used to give individuals that I thought was really impactful. And I think it's like the timeline of health benefits. And it starts with like as little as 20 minutes after you finish your cigarette. And that timeline I always thought was really, really impactful because oftentimes the thought of quitting and the benefits of that seems so far away that it was difficult to have the motivation to make the changes. But when you realize that literally if you stop right now, within 20 minutes, those health benefits begin, it feels like I'm getting a little bit, like what I'm doing is helping right in this moment. It's not so far away. So that's always a good thing that you can give individuals. I also found that oftentimes, and I kind of joked about this when I was doing trainings with VHCs, but like individuals that you're doing smoking cessation counseling with, they don't come back. They really don't come back quite often. And how to mitigate that. And one of the things that I would say is usually, so I always ask, why aren't they coming back? Well, they're not coming back because they didn't do what you suggested or that they created their own plan, right? It wasn't successful the first time, which is probably not going to be, and we understand that. So I always began by telling them that this is the plan. If it doesn't work, that information is just as valuable as if it had worked. So be sure to come back in, because if it didn't work, then we need to rework it and we need to make a new plan. But make sure you're coming in to tell me that. It's perfectly okay if you don't do anything. It's perfectly okay if you increase your smoking between now and then. Whatever that is, no judgment, but come back in and talk to me about it. And that seemed to increase the second visit show rate, because so often it's probably about 50-50 is what we've experienced in the health system of whether or not they come back to that second appointment. And if you give an individual homework, we know that that tends to drive them away. A lot of people don't do homework. I'm not a big fan of it, but with smoking, they kind of create their own homework. So there's not really, can't really get around that. So I do suggest they come in and talk to me about their successes and the barriers, so we can plan for those. And we just keep trying. We try again as long as they're willing and, insurance companies allow and whatnot.
I'd like to mention another thing because it hasn't been mentioned yet. When I was an intern, I had a student patient who wanted to stop smoking and was specifically interested in hypnotherapy. And it just so happened that my supervisor was trained to do that. And she accomplished it in one session. They had one session together and I observed, and he had her come back for a check. I think it was probably a week later, and she had not been smoking. So it may not be at the top of your thinking, but it does work sometimes.
And sounds like that person was maybe when we think about the motivational interviewing and requesting that specific intervention, that they were moving towards an action stage already. They were kind of ready to go, and that particular intervention was helpful.
I also think about callbacks. So a lot of times I will, if let's say that someone doesn't show for their appointment, I will just call and just say, hey, I was just thinking about you. I just wanted to check in. I know these past few weeks we talked about it, but I just wanted to see how it went. And a lot of times I will get follow-up appointments from that call, but it's also a way for me to kind of say, hey, I know this is really tough and I want to be on your team with this. And so if you found this helpful, come back. If you didn't, come back and whenever you are ready for it, whenever, you do think it might be helpful. And I also try to use some of that, honesty too, and vulnerability of what could I do to make it more helpful? Is there anything that could be helpful? I think one of the unintended consequences of maybe some of our policies might be that people feel really shameful about their experience of smoking. So when the doctor says, have you smoked? And they're like, yeah, in their mind, but out loud, they're like, no, I don't do that. Right. But I think if we can approach it with kind of trying to minimize that shame and also talk to providers and teach nurses and providers how to ask those questions in a non-shaming way of, hey, it's okay. I also know there's some insurance policies that won't cover patients if they admit to smoking. So sometimes, there's some really tough navigational issues that we have to know too, as kind of the back end and why people might be fearful of being honest with their provider.
Micah, in response to that, one of the things that kind of popped up was desire versus directive. Now, whenever we have a situation where it's desire that's leading, there's going to be a really decent or a fair amount of positive progression. But when we're looking at directives or being directed to do something, no, it's human nature to be resistant to that and not necessarily want to fall in line with that. So if we have a care provider that's basically coming down in a condemnatory type of way, or as you said, just something that seems almost threatening or invasive, somebody's going to be more reluctant to be forthcoming with information that could be potentially helpful simply because they feel as though that their agency is being challenged. But in the inverse of that, when somebody's coming in because they already have that desire, then it's asking for help, and it's a completely different modal transportation of this information. So I think that's something that we too can potentially address as a community. It's trying to figure out how we can approach the desire aspect and be supportive of that instead of coming down as, this is just a really nasty health situation and using that as a means by which to, come down like a hammer of God and hit people in the head with it. So, I mean, there's a few different things.
Well, for sure. And that makes me think about autonomy, which is at the forefront of our ethics code, and about what we as professionals are expected to do, and those that are leaders in these professions. And that makes me think about the larger ethical picture too, about, when we talk with minors about using, so like Nancy, you said like vaping, and I was like, I had such a reaction because we know too that younger individuals are targeted, and that vaping and juuling are not really very hip. And so those concepts are very much like touted as okay, and they're healthier options. And by the way, they smell like cotton candy, and how can that be bad? And so like that whole moral outrage that I kind of feel towards that, but really thinking about our field and like our ethical obligation of educating people on very, very high risk behaviors. And so when I think about minors, I think about, man, this is a squishy spot, because it's like, we have that, they have the privilege of confidentiality with us, and they have, like, that's part of our ethics code too. And so it's, what do we talk to their guardians about if they're using tobacco products? And so, of course, I think that ideally we would, this is, me inserting my opinion, ideally we would have an open dialogue with them about, okay, what would it be like to talk to your parents about this, or your guardians? And what would that be like to talk to them about how you need some support in quitting? Or even more so, if they use tobacco products, how is that conversation going to go with them? And so that's a really tough spot, which I think definitely increases all of our, tendency to admit, certain behaviors because of the possible negative consequences that we might be ethically obligated to follow through upon.
Adolescence is something doesn't get addressed very often. And you can't convince me that e-cigarettes looking like a USB drive is an accident. It's a fantastic way to hide it. But we do know that most adolescents want to quit smoking. When they've done a lot of polls on them, they want and they try to. And what we don't do very well is educating parents on what this should look like. What should smoking education or tobacco education look like as a parent to a child? Because research also shows we should probably start about age 5 or 6. I would have never thought about that early. But most kids are using by 11 that end up being adolescent smokers are using by 11 and they're addicted by 14. It's way earlier than what I thought until I started doing more research into it. And so those conversations need to happen early. There needs to be a ton of education around it. And then explaining that, the media has an influence here. Knowing who their friends are and having difficult conversations about peer pressure. Knowing what's popular, that e-cigarettes look like USB drives, knowing what to look for so you can have those conversations. I think as farther and farther we get away from those things of ourselves, we just start feeling old. And I don't know what all the cool things are, Michaela, juuling and all that, but I think we have to stay in the know as much as possible. We need to do a better job at educating parents on what this looks like for them. Because I don't think they know how to do it, so it's not happening.
Chelsea, I love what you're saying here. It really overlaps with some of the suggestions from the Mayo Clinic for parents about prevention and several attitudes that you've already discussed in terms of how do you deal with peer pressure when it comes up. They actually suggest that parents make it very clear that smoking is not okay, like to actually go ahead and say no, like this is not an allowable behavior, can be helpful. Obviously, we've talked about the role modeling, the attraction to kids, what that may look like. But again, Mayo Clinic will even suggest appealing to vanity and saying, here's what's going to happen to the way that you look now, which again is a long-term consequence. So it's kind of like needing to have all of these skills somewhere in your back pocket. But you covered a lot of what they would support as well as kind of even prevention.
So Robin, something that's interesting from that as well, looking at the transitions between, we'll say late childhood, early adolescent, mid-adolescent, and the transition from adolescent to early adulthood. Now, if we look at the cognitive stages that any individual goes through in those different processes, one of the primary foci that we could look at really is education on the family at the onset, simply because when we go from that transition from late childhood to early adolescent, that cognitive shift, looking from the familial group to more of the in-group or the psychosocial groups, those type of constructs. If they're not having the education as a basis and the foundation beforehand, when they start to make that transition, they're going to be looking for someone to fill that gap or fill that information gap. And that's exactly where the social groups will step in. And if they get in that wrong group due to in-group versus out-group familiarity, and the desire to overlook negative consequences due to the in-group relationships, there's a much greater chance for those individuals to pick something up that we know is consequentially bad. But again, you can convince yourself very quickly that the negative is good when the group around you is doing it.
It's an excellent point.
One of the main attractions for these particular roundtables is that we do talk about what can I actively do with patients. I want some useful information to walk away with. And so I want to step back for just 1 second. I want to ask Micah a question about her training. One of the things that I did was nicotine fading, brand fading, and aversive tobacco use as part of the process when I was helping individuals quit smoking. Was that part of the training that you had, and how was that received? Because that's oftentimes what we're taught as behavioral health consultants.
Yeah. I'm only smiling because they did say it and they were not happy about it. So kind of what their motto on it was, we don't want to switch. We don't want to have the person switch to a different brand of cigarette because that's not accomplishing anything. They're going to continue to smoke. Their brain is still getting that nicotine. So they really reinforce more so kind of than the step down or the breaking it down. They really reinforce this kind of idea of let's set a quit date and work towards that. They talk a lot about pharmacological interventions and how to use those to help the person. A lot of planning for your triggers, using cognitive behavioral therapy to adapt those, and making sure that we're addressing smoking in that. The other thing that feedback from clients or patients that I've gotten is one helpful piece of advice, or something that I always try to say because I get a lot of positive feedback, is that our brain can usually only hold on to a craving for about 15 minutes. So if we can begin to do something for 15 minutes, that craving is going to go away. And a lot of times people will come back and say, that was the most helpful thing for me, because I could tell myself, I just got to do something for 15 minutes. We joke and say it might be 115 minutes throughout your day, but then the next day it might only be 99. And so the more we can try to retrain our brain to do something else in that 15 minutes, and that seems to be helpful because it's very tangible, right? I have an amount of time, but yeah, they didn't encourage like brand switching or things like that.
I'm gonna remind myself that with cake. 15 minutes, healthy, 15 minutes. How about getting rid of stashes, preparing the people around you that you're gonna stop smoking, cleaning the house pretty extensively, washing all linens and stuff like that? Was that part of it as well, Micah? I need to know how I'm not up to date, apparently. I gotta figure this out.
They did touch on that a little bit. It does seem to be much harder without the support, as we know. So they talked a lot about, even if your spouse or your partner or the person that you're living with, if they're not able to get on board, how can we do that? And there actually are some really great online support groups that I didn't know about that people can join to help them with quitting smoking. I don't know the name off the top of my head, but I know that I found them kind of through a Google search. So a lot of times I have used that as a resource. And then the Tobacco Quit line is an excellent resource because they will get, I believe it's at a minimum of 4 over the phone sessions. And so they do kind of talk about, I think those are good, like clean your space, things like that. But I think more importantly, it's how do we build support and people to celebrate you, whether this quit attempt lasts 24 hours or it lasts 2 years.
Is that the 1-800-QUIT-NOW? Is that or are you thinking of various different programs that individuals could enroll in?
I think that's one of them. There's one specifically from the Mayo Clinic, but I can't for the life of, I have it written down, but
Sure,
it's not in front
you
of
don't
me.
have all of them memorized. Come on.
Right, dang it.
I think the other thing that pops into my mind as a go-to for me was always trying to make the kind of unhealthy behavior more of a pain than the healthy choice. So like taking, the rules of like you only get to smoke outside. And so when it's like rainy or 20 degrees outside, that really minimizes our interest in those things. And also like take your cigarettes or your tobacco or whatever it is and put it in that weird space under our cabinets in our kitchen that like nobody ever uses except for collecting dust and crumbs and weird pots and pans we never use. And so like you have to like dig that out if you want to use the tobacco product. And so it kind of is in line with that, putting off the craving, doing something else, but also, so again, adding all of these layers is going to likely hit upon the different correlates that increase the craving or the behavioral habit, and kind of intervening on multiple of those increases the likelihood. So that was always a fun one for me to talk about with the clients. I could get a lot of their buy-in. They often, poor things, they answered and they didn't realize what I was about to suggest to them. So it's like, describe the hardest place in your house to get to. Right. So.
Also, driving a different route home so you don't drive by the gas station you usually stop at can be a really good suggestion as well. Just eliminating all those triggers as possible. That's the end of our time. Thank you all for being here. I want to remind you that if you did not register, you will not get an evaluation and get CE credits. So you can register online, or you can send Emily an email at support@mopaonline.org. And that will get you registered and get you CEs. There'll be an email survey later today with an evaluation form if you have registered. And then we have upcoming webinars, November 13th, critical race theory, November 19th, forensic psychology. That's 4 CEs. You can learn more about this at MOPA Online/MOPA Learning. And if you want to review any of the previous roundtable sessions or other MOPA webinars, visit the Learning Center at that same web address. Thank you so much for being here. So nice to see all of you. See you next month.
Thanks, everyone. Bye.
We'll go ahead and get going while Nancy is connecting her audio. I just want to remind everybody that this is a discussion, not a seminar. So you can jump in and pose questions or comments at any point. You can turn your audio on and your video on and off as you wish. If it's loud, we go ahead and mute you. You can unmute yourself again then after that if you have another question and whatnot. So participation is completely voluntary. You can also submit your questions via the Q&A at the bottom of the chat, and we will get to those as quickly as possible. If you don't feel like you want to come on camera and ask a question, that is totally fine. Also, this is being recorded. So for future use of MOPA, the views and opinions expressed here are our own and do not necessarily represent the views of any of the Missouri Psychological Association. We are so happy to be here again for our monthly roundtable. Today, we are talking about the treatment of diabetes in primary care. So I'm going to kick it off by having the panelists introduce themselves. I'll start to my left, which is Kristen.
Afternoon, I am Kristen Thompson. I'm the System Director of Pediatric Integration at Burrell Behavioral Health. And this topic is just particularly interesting to me because during my fellowship, I worked in a diabetes clinic at Children's Mercy Hospital. Sorry, I'll kick it to Michaela.
Afternoon, everybody. I am Michaela Muehlbach, and I am the Deputy Chief Clinical Officer of Outpatient and Psychological Services at Compass Health Network. And I'm very excited about talking about this as so many of our clients have this kind of concern. And so looking forward to the discussion today, and always excited to hear questions and thoughts from the audience as well. So, Robin.
Last but not least. Hi, I'm Dr. Robin Lute. I'm a licensed clinical psychologist, currently working at Compass Healthcare. Again, just to echo the sentiments of my fellow panelists here, really enjoy these times when we have good conversation, and we really welcome questions, concerns, comments, as you are all also experts. And we know that diabetes is a huge contributor to so much morbidity and mortality currently in our country. So looking forward to another great hour.
And I'm Chelsea Gillum. I am the Assistant Director of Adult Integration at Burrell Behavioral Health. And I'm just going to start off today by giving some just baseline information on diabetes so we can go ahead and get that covered, fill any gaps that might exist. I would say a lot of you probably know this, so you need to zone out for a minute. That's perfectly fine too. But I think this is all important for building the case on why it's important that we are present and also treating diabetes in primary care. So diabetes itself is just a chronic disease characterized by elevated blood glucose levels. Basically, the pancreas in type 1 is just not making enough insulin or completely stops making insulin. And then that glucose remains in the bloodstream and doesn't get transferred to the cells. Those individuals with type 1 diabetes, they must take insulin to live. And this is mostly genetic, but there is some arguments that there are environmental factors early in life that also can contribute to diabetes as well. So both type 1 and type 2 are genetic and environmental. Type 2 is much more common and what we'll see a lot more in primary care. This is where insulin just becomes less effective in helping transport blood glucose to the cells. And if it's left untreated, then for several years, those cells progressively become more resistant to insulin. and the pancreas just continues to make more and more to try to keep up. Risk factors for type 2 is being overweight, gestational diabetes, a lack of physical activity, and being a member of certain races or ethnicities. Also taking atypical antipsychotic medications. So a lot of times we'll get those referrals when someone is just has insulin resistance, maybe they're pre-diabetic, is the referral and they need to work on some of these lifestyle changes. And so that might be when we get called in, or it may be when they've already got a diagnosis. We see that diabetes is increasing substantially. Between 1980 and 2011, the percentage of population diagnosed with diabetes increased 167% for those ages 44 and younger. 11.3% of the population in the US has diabetes, but from ages 20 on, that is 26 million people. Another 35% have prediabetes. So this is incredibly prevalent, which is one of the reasons we want to make sure we did a roundtable on this, because the comorbidities that we see with diabetes in primary care are pretty substantial. Individuals with type 1 often come in with frequent urination, unusual thirst, extreme hunger, usual weight loss, extreme fatigue, and irritability. Type 2, you might see mild or no symptoms. They may have the symptoms I just mentioned. They may also have frequent infections, blurred vision, cuts and bruises that are slow to heal, tingling and numbness in hands and feet, reoccurring skin, gum, and bladder infections. And so the doctor's going to be asking those questions as well if they're pre-diabetic to see where they're at as they progress. And you might hear them use these things, saying, I'm having trouble just transitioning with this new diagnosis, and the physical ailments that kind of are the precursors and just part of that symptomology. So I think it's important we know what those are so that when they use that language, we know where that's coming from. There are, for kids, I think, Kristen, you're our kid person. It's similar to this, but there's other things that you would want to pay attention to specifically. Do you want to talk a little bit about that with children?
Particularly, so type 2 is very similar to adults. And although type 2 in particular in children is tied to diet and obesity. And it's something that, generally speaking, if a child has primary care, is on their radar. What can be really scary about type 1, which does most often present in childhood, is it often there are no warning signs until it's really upon you, and families find themselves where their child is really sick. They've had an episode of diabetic ketoacidosis, which is DKA is the acronym for that. And that's essentially where their untreated diabetes, untreated because they didn't know about it, gets so severe that they just become really ill. They get hospitalized. They don't know what's going on. And then quickly, identified as being diabetic in the hospital. And so I think the important thing to know there is for families with type 1 diabetes, oftentimes this is a sudden and sometimes dramatic and traumatic revelation for the family. And that is where really behavioral health becomes very important there too, just dealing with a new diagnosis that has come on in a way that is surprising and sometimes scary. But in terms of the other thing I would add about just signs and symptoms, especially with little kids who can't communicate necessarily with you as well, some of the warning signs that are identifiable are increased thirst and hunger and increased urination. And there's actually, it seems like a really random symptom, but fruity smell on the breath. It's because of the sugar that builds up in the body, but it's really noticeable. And so that's oftentimes, when you have these other nondescript things like increased hunger, thirst, and urination, but then you have that unique symptom with that. That's one of the ways it gets identified.
If I may jump in for just a moment, we always give attention to cultural factors during these lunch and learns. And I just want to tag off of what Kristen is saying in terms of the diagnosis for people of color, for other minorities, tends to be delayed often, especially in childhood. Some studies would suggest this is implicit bias. Some studies will get a little more complex into health disparities in general. But there is certainly evidence to support that once the identification is made in children, They don't tend to receive, in children who are of the minority population, they don't tend to receive the same level of care, the same intensity of care. So just wanted to throw that in there as a basis for other comments that I will pepper through in terms of recognizing that as many people have this, it is definitely biased towards some minority populations as well.
I would say, like one of the clinics that I worked in, one of the things that we did is we put a pathway in specifically for anybody that was newly diagnosed with diabetes, because that transition from getting the diagnosis to all the changes that they need to make is pretty significant. And I was going to ask Michaela or Robin, either of you kind of at Compass, how is it that you guys go about treating diabetes once you get those referrals, whether it's from a pathway that's already in place, maybe it's a comorbidity that you're seeing, but you're realizing they're having trouble with diabetes specifically. What do you do?
Oftentimes, it probably isn't surprising to anyone on this call that we oftentimes see that in the primary care setting. And so our BHCs are just totally integral to that particular issue. And so typically the BHCs will kind of capture that referral. They'll start working on behavioral management, education to the parent and or the client, and also working alongside them to, if they need extra support. Like you said, it's such an impactful diagnosis that changes so many parts of their lives, that should they require more kind of in-depth or intensive supports that maybe we can't provide right there as a BHC, we can make sure that our outpatient team wraps their arms around them with ongoing therapy or case management, maybe even psychiatry if that's not indicated. I think that I'm always interested in hearing about what the BHCs that we have on these calls have to say as well. But I think one of the most pivotal things that can be so wonderful about having the BHC is that they are kind of the link oftentimes between primary care and outpatient. And that's just, I think that's just the most important thing is we may not be able to manage everything right there, but we can definitely link you with people who can. But I don't know if others have any other thoughts, but that's kind of the high overarching view of what we would do.
You kind of hinted at this, Michaela, but just to highlight that there are a lot of individuals, and somebody may speak to this more specifically, the overlap, the incidence of individuals who have diabetes who also have depression, whether it's sort of what we would call a reactive depression to all of the changes that need to be made, or an endogenous type depression because of all of the hormonal changes and medications. The prevalence of depression is extraordinarily high in individuals with diabetes. And so you were talking about wraparound care, even psychiatric services. Certainly we do see that is often, again, we're playing maybe a bridge role to getting individuals to some more intensive care or different type of care. There's also that version of very real diabetic burnout where an individual just every choice every day is impacted. This disease, it's essential to be hyper vigilant almost with your lifestyle. And so that can get really old, for lack of a better word, for lots of people.
Yeah. And one thing, Robin, you kind of triggered a thought in my mind too, which is it kind of harkens back to our discussion a few months ago about eating behavior, and that oftentimes when individuals do reach a point, like a tipping point, so to speak, that there are oftentimes emotional and or behavioral health reasons why individuals reach that tipping point. And so helping with that kind of underlying reason of what are we using food for, and kind of understanding that perspective a little bit better can be really valuable. And sometimes that can be done in the BHC setting in primary care, and sometimes that needs more intensive treatment.
Robin, you mentioned that burnout factor, and it reminded me that a few times when I was treating individuals with diabetes and they were not making the changes that was recommended of them, which is how I got that referral. A lot of them talked about how this diagnosis came off of something large in their life. So like they already just quit smoking, or they just got they are in cancer treatment, they just finished that. It would be something big. And then they get this kind of diabetes diagnosis that requires substantial changes in their life. And they would say, I can't do one more thing. And so I think timing is huge on this. Sometimes, I think they get a lot of information on these are the things that you need to do. Now go do them. And there's no thought to why that might be really difficult, which is the beauty of why we're there, right? Like we get to ask all those questions and kind of dive into that. But you're right, and Michaela hit on this, like there are lots of reasons individuals might not be engaging in those services and doing the things that they're being asked to do. As with anything that we get a referral for. And then with diabetes, you mentioned the high rates of diabetes. Actually, individuals with diabetes have a doubled risk of depression, literally doubled. So pretty significant. And what we see overlap with depression. We see overlap with anxiety as well. There's an increased risk. If you have diabetes and having anxiety, also schizophrenia, higher rates for type 2 diabetes. You think about mental illness though, generally individuals are they're not going to at the same rate engage in their care. They're just not. We see that across the board. And so anytime we have this comorbidity of diabetes or some other chronic disease and we have mental illness on top of that, their risk increases substantially. Now, determining whether or not which one we treat first, that's the tricky part is BHCs. Any thoughts on that?
I just want to piggyback off your comments about burnout. And so like I've been doing this and I'm burnt out, or I just can't do this. And that's a huge factor for kids and adolescents too. No, you don't have diabetes. That just totally gets in the way of everything, right? And think about how limiting that is for a child, really at any stage in development. It impacts everything. It impacts sports. It impacts, can I go on a sleepover? It impacts, can I eat the same things as my peers at lunch? It impacts, it's Johnny's birthday and they brought cupcakes. And can I have this? How do I have this? Do I have to have this differently? It just makes you different. And kids don't want to be different. And it can be so difficult, especially as a child. Your developmental perspective is that I'm invincible, this can't hurt me, and all the consequences of diabetes are really far away. So it can be really difficult to engage kids around treatment and get them to take it seriously, for lack of a better way to say it, because there's just so many barriers. So a lot of times we'll have kids who maybe they do okay in the home setting because you have the parent really managing that. But when they have a layer of independence at, practice and school and whatever, where they have a helper there, the nurse or whoever to help them, but it depends on the child engaging with that helper, things really fall apart because it requires that child's engagement rather than somebody coming to them. So that's really hard. And the other thing that's really hard, thinking from the diversity lens, Robin, not every family has access, not just to care, but to healthy food, to exercise. Diabetes is really complicated. What's a carb? What counts as a carb? How do you count those? How do you track those? Not everybody has the executive functioning skills, let alone access to, diet and exercise tools. It's really complicated. It's a lot to keep track of. So that too, you think of kids who developmentally may not have those things, or just families who are stretched and exhausted and tapped out and don't have a lot of resources. And then you layer this on and it can be incredibly difficult. Even if you get the diabetic educator in and the dietitian and you teach the things, actually implementing those is really behavioral. And sometimes it takes someone like a BHC, someone from a behavioral health background who can break down what the actual structural barriers are to help them get to a place where they can actually apply the education that maybe the diabetes educator has given. Sorry, that's a lot. I had a lot of things that I wanted to comment on.
I think it's great. You apologize, and the only reason I'd say apologize is because it did the same thing to my brain, where I want to comment on 15 different parts of what we're currently discussing. You just picking that diversity piece for just a moment. You mentioned access to food. I mean, often when we're talking about, we all know the overlap, the overrepresentation of indigenous cultures, people of color who are overly represented in terms of poverty levels, and areas like food deserts, where even if a person learns choices and learns how to make healthy choices, it may simply not be possible for somebody to drive to go get the appropriate kinds of foods if they're not available in their neighborhood, which does tend to happen again in lower income neighborhoods for sure. Diabetes prognosis can be pretty well predicted by zip code, which is a really interesting and almost frightening thought that outcomes almost follow a linear correlation with zip code. So to say that, the setting matters in this case is an understatement. In addition, we haven't quite hit on technology yet, but children of color are not going to receive as much use of insulin pumps. They're not going to be offered the treatments that tend to make life just a little bit easier in terms of managing that glucose. Because the other piece of that, Kristen, you said once people learn what are the macros and what are the carbs, and it's still changing. It's not like you can learn a formula and then that's what you do every day. If your stress level goes up, and again, we know, people of color who sleep at night, their cortisol levels don't drop the same way as white individuals will say. So it's, again, sorry, as Kristen said, but it just made my mind go in so many different directions. This topic is just so complex, from diagnosis to prognosis. There are just so many factors that matter.
And absolutely, I echo everything that others have said. And the other piece to this is systematically working within the team. The joy of having a large system is that you have so many other team members, and the downside of that is then it almost becomes a little overwhelming to know whose role is what and who should be doing what piece. And so we often recommend, I always feel a little bad for our BHCs because we're always saying that they're a great pivot person. They're kind of traffic cops as well. And a large part of what the BHCs do in addition is to really help what was just mentioned, talking to the providers about, these individuals have a higher likelihood of having co-occurring mental health issues that we also need to address. And so being able to remind the providers and then turn around and support them with those pieces is so invaluable, as well as letting the entire system kind of be aware of what gaps in care do we have for individuals who are presenting to our primary care providers and clinics, and where does the administrative leadership kind of have the opportunity to kind of step in and provide the resources that are needed. Maybe it's a grant to purchase those glucose testing kits. There's a lot of different, I think, spaces that systematically and kind of provider education that there's a lot of opportunities there.
So when you say systems, it always makes me think of the family system too. And I know we always talk to parents about interacting with your child with this new diagnosis and how is the family going to change? And those kind of conversations are fabulous, but I think sometimes where, and I'm guilty of it too, where we miss the mark is we forget about talking with the parents about the siblings, because now we've got a bunch of other kids here who are going to have changes in their world, changes in the food that's brought into the home, changes in what snacks are available and what aren't available anymore. And can I eat this in front of my brother or my sister now? And those kind of conversations are huge because it's not just the kiddo that's experiencing the change, the whole system.
Thank you, Caitlin. Yes, 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 yes. And how true of this is this of so many kinds of things, right? You have a member of a family system who has X new diagnosis and it requires X things of them. Whether or not the family gets on board is going to have an impact either way, right? And you have to decide as a family how you're going to do this. If the family doesn't get on board, then that individual feels isolated and alone, and they have to follow all these rules that nobody else has to follow. And that's really hard. I've seen that. And then I've also seen how, the parents say, okay, fine, the whole family, we're all in, we're not going to do this anymore or that anymore, and we're support you and we're together. And then everybody's struggling through a lot of change together, and there's unity in that, and there's a lot of solidarity, but it's really hard. And then you have to deal with the siblings' frustration, and it's just really complicated. And to neglect the impact this is going to have on the whole entire system, absolutely, Caitlin, to use your words, misses the mark. And if you're not preparing the whole system to be thoughtful about what they're going to do, how they're going to do it, and what impacts those are going to have, you're going to miss. So thank you, because that is absolutely our role. And that is a place where we have something unique to offer, because that goes above and beyond the carb counts.
That's a really good point. And I just want to echo that, but that also occurs in an internal med with elderly as well, is that they have oftentimes lots of like gender stereotype behaviors. So we have a lot of women cooking, and they've cooked the entire relationship. And now one person has diabetes, sometimes her. But this means that the entire family or the spouse is going to eat differently. And we see a ton of resistance after 60 years of making that change and adjustment, to the point where they just say, it doesn't matter. It doesn't matter. I'm not going to make that change. Even we see a lot of domestic violence in that population that we don't usually talk about that, but a lot of that actually occurs around food changes. I've heard many stories of people throwing plates against walls and things like that when they were served something healthy or different than what was typical. And I think we need to talk about that more, about how that system needs to make that adjustment and how the family needs to be part. That some of that we need some changes with billing insurance companies so that we can actually pull the family in and have those discussions, but that's for another time. But we absolutely need to make sure that we are doing those things.
It's really interesting to hear. I mean, having worked with diabetes in different ways over, gosh, almost 2 decades, I had no idea that things would get that intense. I almost feel badly that I made sort of a lighthearted remark over here, give me my meat and potatoes in the chat, which is kind of the conversations that I do hear, like you said, especially if the woman's diagnosed and she's doing the cooking, although now it makes me feel a little bit like I shouldn't have been silly or lighthearted about it when it's getting to a domestic, an interpersonal violence level. That's really profound.
I wish I was just being dramatic for like sake of remembering information or something, but the amount of conversations that we have about domestic violence in internal medicine is pretty heavy. It's on a daily basis. That's one of the main things that we deal with. So any changes, whether it's exercise and leaving the home or joining a gym, whether it's food changes, whether it's just attending your medical appointments or seeing a behavioral health provider, all those things really trigger that common theme that we're seeing in internal med, which is that we have kind of an angry system.
Well, yeah, many times you have the person who is the primary cook making those changes, and the other person who is the diabetic is refusing to do it, or looks like they're complying, and then there's fast food wrappers in the car. And if they're in a work setting, there's other kinds of things. And so there's a lot of issues between the spouses. And the other thing, for those of you who deal with kids, it's not only the nuclear family. I've had grandparents want to blow up the system because, oh, you poor thing, here, have a gumdrop or have this, and not being on board with what needs to happen, because particularly if it's a younger child, somehow seen as deprived. And how could it possibly be Halloween without the real trick or treat candies? And yes, they can have some of them, but they can't OD on them. And then you have to know how to adjust, you know? And the other thing that I've seen is that parents who get this diagnosis for kids, and they are like a super control freak, and they're losing their shit, and the kid is fine. The parent is nuts. I've seen in meetings that involve general education for the public, parents absolutely lose their shit because their job is to get every note in every conference and write it all down and go home. And I think that the hidden secret is you can do the appropriate thing, the same thing day after day, and get different results. This disease is a weird one. You can do everything that you need to do, and you get an F on your report card when you walk into your primary care docs or pediatricians, and your HbA1c is not whatever it needs to be. And it doesn't mean you haven't been doing everything, but if you're just doing, blood sugar checks 4 times a day, you're not noticing that someone's got a 300 blood sugar all night long. And again, technology is really moving, and some people have access to it. Not continuous glucose monitors are now starting to be the standard, and not every insurance company is going to go along with that. The supplies are very expensive, and it's a challenge, and to use that. And also it's a control thing, because there are parents now who on their Apple Watch have the Dexcom reading, so they're in touch with the school, the kid, and another spouse, because you can follow this kid, which has positive, but also can be a little too much. Big brother and big sister, and mom's always watching and knowing what I'm doing. So there's a whole lot of new stuff coming down the pike, which is great, but it also adds that complicated layer.
Yes. Oh man, our round table is activated.
Yeah.
Those are
Listen, I mean, I don't think endocrinologists get it. I'm not kidding. I've done this work for a bazillion years, and things really changed when things started to happen in my family. And I felt like, boy, I'd like to go back and apologize to some of the families and some of the people I've worked with over the year. I'm a much better psychologist for someone with type 1 or type 2 diabetes, particularly type 1, than I used to be. And it's because I have personal knowledge and I understand stuff that I thought I understood that I didn't understand, but now I get. And I think that's always, that's always tricky. But I'm amazed at the resources that parents initially use, and a lot of other adult diabetics now that are out there that are you can access at Zoom meetings, you can access on websites and all, and they're on the cutting edge of what's going on, who's doing it, and how it works. By the time it gets to their endocrinologist's office, it takes a while. And if they've seen 25 patients that day, they're lucky they remember their name, let alone say, oh, by the way, you might be helped with X, Y, or Z. It depends on what drug rep just walked in their office as to what they're pushing.
Yes to all of that. And I really want to pause for a second on that point of their team may not know that their endocrinologist or their nurse educator, they may be missing something. And I, as the BHC, I mean, it sounds like you're wonderfully educated, and there are many people who have lived experience of this, but most behavioral health providers know very little about it. And so how do you walk that line? And how do we avoid saying, well, if you would just do what they told you? That's the hardest part, because we don't want to be another part of this system where we're just saying, well, how do I help you do what they told you to do? Because that's just so not it sometimes. Sometimes there's just a missing piece and nobody's quite put their finger on it through no intention. It's just missing. And how do we empower our clients to work with their team, or to try and uncover something when there is something missing? It requires us to be communicative with our team and to have a working knowledge of diabetes without overstepping. It's really tricky. And so I think that's just such an important piece you highlight.
Well, I think besides doing a hell of a lot of CUs by Zoom in the last year and a half now, That's one of the things I've been able to do is access some conferences that I had thought about going to, but I didn't have the time, but I could do it, and to see kind of what's out there. But for many of us, that's not the only area we work in. It's just that, okay, I can pay more attention to this one. And it really, it really varies. And it varies on what part in the progression they are in terms of how old or new the diagnosis is. And then you also add the whole adolescent piece. What better to fight about with mom and dad? You want to control me? Watch what I can do. I'm going to do this, this, and this, or not do this, this, and this, and watch my parent get even crazier, trying to control me.
And then how do you, so you have all of that dynamic happening, right? And you also know that your child's about to leave your house and they need to manage this on their own. And how do you help families navigate that? Because it is so hard, especially when you have the parent who is extremely knowledgeable and well-informed by their Apple Watch. Because even if you take adolescent rebellion out of the equation and you have a child who's really trying to take responsibility, what's the parent do when they see that they've done it wrong? They're getting notifications.
And again, it's the right and wrong, but the irony of the whole thing is because of one of these parents that one of these cutting edge systems has been developed, and it's not FDA approved, but it's just about there on the artificial pancreas, because this engineer had a son who was diagnosed as a type 1 diabetic, and he was bound and determined to figure out something that was going to get close to an artificial pancreas by the time this kid was ready to go to college. And I believe he's now a freshman or sophomore at college. But this was a BU project, and he hooked up with the diabetes people at BU. And, they've developed the system. And it's got both glucagon and insulin in it, so it can do a variety of things. But I mean, and the same thing, the whole thing with the watch, before there was the Apple Watch, I'm thinking it was 6 or 8 years ago, there was a website called We Can't Wait. And I had a parent who had some kind of throwaway cell phone attached to a Dexcom that attached then to her she had to have a special kind of watch, and parents figured out, and her husband could do this because he was an engineer and knew how to jerry-rig the different parts that you get at Radio Shack. Now it's more part of like the Dexcom system. But I mean, that was driving a lot of it because we need to know more. But even those systems, it's not set and forget it. You have to interact with it and understand how it works. And I think there's a piece that many people don't know. It's not only the carbs, but fat and carbs, or protein and carbs, or fat, change all those parameters. So there's now some work looking at how do you change the bolus, the amount of insulin you give to a type 1, if it's not only a high fat meal and a high carb meal, but based on the protein and things like that. So again, all these factors, and some people talk about it, some people don't talk about it. And sometimes you can tease out and find information, and sometimes people talk about it and you can't find the source. So it kind of varies. But I think where you have to meet your people and your families is where they're at. So many ways you're being told you're doing something wrong because a lab test tells you, and there's nothing more aggravating than that. When you've done what you need to do and you're having someone kind of be a little judgy with you.
I think it's important to remember that sometimes a referral to us feels like judgment. So we do that immediately.
Oh yeah, when you get their referral from I worked in a different setting. I work in private practice, but even as an intern 100 years ago, when you get their referral from a med-surg floor, you're in for a ration of shit, because you're walking into a room where they don't want you there, and the doctor very often has not prepared them that you're coming, but they're so frustrated they don't know what to do, and the patient's first response is, so they think I'm crazy? No. So we've come a long way since then with integrated teams, which is great. Yeah.
Huge part of that acceptance, I think, Elizabeth, is how the physician team introduces the BHC themselves and the role of the BHC. It's very important for us to have all of us to have our scripts in terms of how we introduce ourselves and how we kind of interact and introduce one another. So I agree with you. The progress there is really substantial, that we're able to work together quite a bit more effectively. And I don't know if others who are working actively with physician teams as BHCs or as psychologists, counselors, have thoughts or ideas about how we best do that, how we, what makes us successful in terms of introducing our role.
So I can give my 2 cents on that. I think, one of the things, just a BHC staple, is I'm part of this team and trying to coach the providers to introduce you as a team member and really focus on the primary care setting and get away from I'm the therapist. So I'm part of this team. I come in and meet with families when they're struggling to make progress, with X, fill in the blank. And I usually just have a little bit more time to sit down and kind of help a family break apart the issue. So sometimes I introduce myself, especially with these medical components, as I'm kind of the detective or information gatherer, investigator. I can come in and really break it down with you and then work between you and the team to try and come up with some solutions, because I've got time and we can really just sit down here and talk through it. So I don't know, I think that feels a little bit less, I'm going to come in and deal with the behavioral health part.
I have a question about something Noah wrote about thin privilege. Are you saying that a patient suggested that you couldn't get it because you're thin and you have no idea what it's like to be me? It's in the chat thing.
Yes, essentially that's the implication. Yeah, it was an interesting conversation.
Yeah, well, that's one more way to say get off my ass, because you can't understand it. But the problem is, it's like having a size 3 nutritionist talk to you about not using certain products, and you're thinking, yeah, you're a little chickie in a tiny little outfit, But the reality is, we don't know what's going on in that healthcare provider's life, But that, yeah.
Interesting how sometimes we are judged and having to deal with that kind of transference, just to use the broadest term.
Don't you know we have the perfect families and the perfect kids and the perfect everything, because we're psych.
Well, I'm coming to your house, I think.
No, I don't think so.
But I mean, it's somewhat of a, I don't know, like a, I don't know what the word is. I have not had lunch yet, sidebar. So struggling with word retrieval, hardcore. And so I think that is a space of diversity, though. Like, the assumption is that you can't have diabetes if you're thin. I think that is another space, right? Or that you must not struggle with eating if you're thin.
Very nice.
And also, you can't, only kids get type 1 diabetes, and it is the majority, but the reality is that there are people in their 20s, 30s, and older who, out of the clear blue with no family history, can get type 1 diabetes. And what the feeling is it often happens in the spring. Perhaps there's a virus or a flu or something that starts to attack the pancreas. But again, endocrinologists make the assumption, oh, you're a chub, you must be type 2. And sometimes as a patient, the patient has to say, give me the magic test. There's a couple tests to see if there's any pancreatic action. Surprise, surprise, this is a whole different thing. It's a whole different class of medicines and treatment you need, not the typical go see the nutritionist and lose weight nonsense. So that will vary. I have a question about those of you who live out more in the rural areas, because many families are, we eat certain ways and we eat certain foods, and this is the way we've always done it. And it's hard. Is there any resistance to changing some of those things?
100% say that in rural areas that there are stapled meals. And I think we see a lot of that. I was thinking that earlier, we were talking about individuals struggling with that transition. that sometimes it's really cultural for rural areas or the Ozarks for where we live, that there are just staple meals and that things pretty much stay the same. Change is difficult for Ozarkians in general, in my opinion. And so that's just another one of those things. I think that there's a cultural component to that. And also I just want to say before, I want to talk about Noah's comment here just real quick. My thought on when people bring up, you can't understand because of this reason, the underlying emotion of that is that they feel incredibly misunderstood and unheard. And so I think it's important that we hear those things, that it doesn't actually become about us at any point, that it is what is the feeling that's behind that, and then how do I reflect that back to them. So I think that way you don't get caught up in like the nuances of, is it true or not? It doesn't matter. We all know that that's not an accurate statement. You don't have to have a broken car to be a mechanic and those types of things. So, but you do have to understand what the emotion is behind it. That's a good focus. Any other thoughts on rural care? Because I want to make sure we hit that other than what I just said.
Did you say rural aspects?
Yeah.
Yeah, so I've worked with, in Kansas City as a BHC, I worked with a lot of Latinx or Hispanic individuals.
Yeah.
And we would ask them as part of a program to adjust their diet. And of course, their diets can be high in carbs, like simple carbs specifically. And that can be a challenge, like tortillas, rice, things like that. And so we were asking them to give up a lot. And so we had to navigate that aspect of their culture and their identity in like a respectful, tactful way.
I think when I also think of rural, I think of health literacy. Where access to healthcare is low, health literacy is also low. And you think about extended family involvement, which is important. And you think about family gatherings. How much pressure are you getting at a family gathering where, now you have this big extended thing where something has to change because of this one person who, why you listen to your doctor about that anyway? Or like, that's not that big of a deal. Or, your grandma raised me on fill in the blank. And there's this push against the change that impacts the system and the status quo. And part of it is because of mistrust of the healthcare system and difficulty changing generational patterns. And it's wrapped up with low health literacy and a whole big complicated mess of things that are part of the rural culture.
That was well said.
Oh, and don't forget, we have the holidays coming. It's the holidays. It just wouldn't be the holidays unless you ate blah, 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 blah. Oh, just this one time, it'll be fine. Oh, so we have to take you to the ER the next day because you're in a coma. Sure. No, I'm being a smart ass, but it's not dissimilar to someone who is doing other health kind of things to lose weight or has a cardiac or kidney issues or whatever. And everyone wants to convince them, it's okay, just this once. And so basically they're being told, well, it really doesn't. You and your health issue don't matter.
Right.
Americans celebrate with food. We do.
I don't think we're the only culture that does that.
Well, we're so heavy on unhealthy foods. Unfortunately, it is, I think, part of rural culture as well as the broader American culture. I mean, certainly we see pockets. I've, lived for a long time in California, and the culture was very different with respect to the function, as Michaela mentioned earlier, of food and what food is about. And you're right, it is very common to celebrate with food. It's just when we have supersize the supersize and sort of excess, and it's so easy. And that's another piece of where certain populations will struggle. Kristen mentioned access to healthcare, and again, access to healthy food or the ability to even afford healthy food if it is available. It's just a challenge for a lot of different areas. This is heavily cultural dependent. It makes me think so much about, could we think of a diagnosis or a disease process that more specifically benefits from the biopsychosocial sort of spiritual model? I mean, it's just so dialectic in terms of all of the complexities that are interacting, and we really have to have a broad conceptualization of how to be helpful.
So on that note, then, a lot of what we do as a BHC is diet changes and working to motivate an individual to make those changes in ways that have not ways that they haven't gotten before, by identifying those barriers and kind of busting through those, talking about underlying issues that might create those barriers. So diet, exercise is another big piece of this. Actually doing your blood sugar testing is a piece of this. Foot care may be a piece of this. Stopping smoking is a piece of this. So that's kind of what encapsulates as far as adults on how we treat them and how we focus, but ultimately give them a different experience, because I'm guessing they came to you because it's not what they've tried before has not been successful. What people have told them has not been helpful. And so like Kristen said earlier, we have to give them a different experience. We have to do something different than what they've had. So anything that I'm missing from that on kind of generally what our treatment focuses on, or any other thoughts?
I think one thing we just haven't hit on at all is that when blood sugar rises and falls, that can also contribute to mood changes. And so sometimes, even if we're not talking about a standalone diagnosis of anxiety, depression, with kids' oppositionality, irritability is a big part of blood glucose fluctuation. So I think sometimes, even if you don't have a secondary or primary behavioral health diagnosis, you're still getting lots of psychological and mood impacts of blood sugar. And I think that's an important thing for BHCs to be aware of, because we still have a role in helping families navigate that and helping use mood changes, not just as sometimes it's a warning sign that you need to check your blood sugar or something's going on. I'm feeling irritable or tired or lethargic or anxious. And that's a sign, but also, I am going to experience that, and how do I manage that?
But I think educating families on how to do that appropriately, because the problem is, if you want to see a kid or an adolescent or even adult get angry when a family member turns to them and says, you need to check your blood sugar, and it's like, no, we're having this argument. I don't need to check my blood, whatever. The point is, then it's another thing to be angry and upset about because you're trying to control me. And the family member is trying to give them a piece of information that they're concerned about this. And again, how do you get the kid in there so that is there something that the kid and the parent can work out so that mom or dad can say something that lets them know maybe they need to do something without actually saying, you need to check your blood sugar.
Yes. And in fact,
when was the last time you checked your blood sugar?
Yes.
Those are fighting words you throw
They
down.
are. And even something so subtle as I worked with families where they have a code word instead, because otherwise you need to check your blood sugar as code for like you woke up on the wrong side of the bed. It is.
Have you taken your meds today?
Right. Yeah. But if you can just, if you just have a subtle, quiet code word, ladybug, it's like a cue of like, oh, but it's not leveraged as an assault. And I think that's such an important thing where the intention may be the same, but the way it's received is so different.
Does anybody else feel like we need a part 2, 3, 4, and 5 of diabetic
10,
care?
20, 30, 40, 50.
Yeah.
Well, but I think even as psychologists or mental health folks who work in this area, many of our colleagues, oh, you do that stuff. I mean, I've been doing healthcare stuff when people, for so many years, it was when people said, you do what? Now it's got legit, now it's healthcare, now it's this, people are integrated into systems. Many more mental health professionals are educated in all kinds of chronic health issues that we maybe were not before. But I think a lot of our colleagues still don't quite get it.
Mm-hmm. Elizabeth, that's a good point, because I always want to make sure I say this, that even if you're not in integrated care, these things are so important that you know them. They're still walking in your office. And so even for the individuals who aren't working necessarily in healthcare or physically located there, these trainings are great for everybody.
Mm-hmm. And that actually also, Elizabeth, made me think about Chelsea's initial question at the beginning to me and Robin about like system-wide, what do we do? And so it's not just about like us educating in the primary care space, it's also about us educating in the outpatient space of what kind of things to maybe look for if you have a patient that might trigger a recommendation or a referral to primary care. I noticed that there's a lot of us on this that that are having a lot of dialogue in the chat. And I just really appreciate and enjoy hearing all that information. And I think that keep talking, I guess is my point. Like, we keep talking to each other, we keep talking to our colleagues, and keep talking to the people that we work with. And I think that we just continue to learn from one another, and system-wide that eventually we'll all kind of know. I say it all the time, but everybody can agree that integration is such a great idea. Oftentimes it's hard to figure out how to do that. Who do I go to? Where do I go? What do I ask? And so just ask somebody.
I have a question. Someone mentioned the chat box diabetes distress scale. Where does one get that?
It's online. You can get online. I think
Online?
it's also in the purple book, but it's probably updated. I don't know. I don't really know where I got it, but I have it and I used it. I think it's online.
Okay.
But
All right.
yes, you look up
But you-
diabetes distress scale. It's got lots of good questions about how they feel, which is what I really like about it, because then you can kind of gauge whether or not how fearful they are and how that changes as you treat them.
Chelsea, it's available online.
Thank you, Justin.
I
Great.
think I just
You're
posted
welcome.
it in the chat.
Any final thoughts here as we approach our 4 minutes?
I guess I just want to echo Michaela and what everybody's saying here is just keep asking questions, and don't, I feel like this is true of everything we talk about in these roundtables, but don't feel like you can't intervene in that space. Yes, it's important to stay in your lane. Yes, it's important to educate yourself about the presenting problem, whatever it is. But this is just all human behavior, and this is our space too. And there's a lot we can do to help. And if you're motivated to learn and ask questions and be vulnerable, and even say to a patient, you know, oh, I don't know as much about that. Can you tell me some more? And then you Google it before the next time you see them, so you can fill in the gaps. But just be curious, just like anything else, because none of these medical things should feel scary or off limits, because there's a lot of work to do.
You know, I was going to jump in and say something very similar to that, Kristen. You know, in the grand scheme of things, we have to remember that you know, we don't dehumanize those that are going through this. That diabetes, though it's a really relevant and prevalent type of thing to go through, I think we have a tendency at times to find ourselves in a position where we focus more on the disease, not the person. And you know, diabetes is such a challenging thing to work through. It's easy to manage in theory, but it is such an impact on the livelihood of all people around, not only themselves, but as we said, those that they interact with. So as we learn with one another and grow with one another, it's just trying to remember too that the patient is going through a lot of transitions, and unfortunately it's going to impact so many different lives around that individual as well. One of the best things we could possibly do is make sure that we have open ears, open eyes to see, hear, and do the best we can to understand where they are, try to understand best the familial area they're in, if they have it, what type of support group they have. We also, I would say too, need to understand that we may be the only support system that some of these folks may have, especially from those that are from a disenfranchised background or just a very solitary background. No, they're going to be fighting this alone. Now they have to change the entirety of their lives. They've reached out because they've run through these states, and we may be that last person that they can look to help, you know, guide them through this path.
Well, I think also we have to see them as a person with diabetes, not a diabetic, because, you know, if someone's tall or short, we don't call them short or tall. We call them a person who is short or tall. But also, that's just one of the things they're dealing with in the life. And that might seem very minor, but it's very important, because they are not 100% diabetic. They're a mother, they're a father, they're a child, they're an athlete, they're this. And there are ways to do just about anything you want, but you just have to think about how you might go about it. And that, I keep thinking, be one of our jobs, because we can be the one that says, sure, why not? Go for it. Let's think about how you go and do that.
And you have a better ending than Kristen and Justin and Elizabeth just then. I'm going to absolutely stop that there, because that was a perfect 3-part ending to this roundtable.
Only if you guys call me Liz from now on. I don't go by
Okay,
Elizabeth.
Liz.
Okay.
Just before you go, I'm going to give you the upcoming webinars that we have. On October 15th, we have History and Best Practices of Police Candidate Assessment and Psychology. November 13th, Critical Race Theory. What is it? what it ain't, and everything in between. November 19th, forensic psychology and overview. You can learn more about all of these at mopaonline.org/MOPA learning. November 4th is our next roundtable. It actually has a 1-hour free CE for that for all MOPA members. So if you want to access any of the old archives, you can go to mopaonline.org, and all the other webinars are there as well. Thank you all for being here. We will see you next month.
Thank you.
Thanks, everybody.
Bye-bye.
Bye.